So it's a great pleasure and honor to welcome you today for this class on the law of EU external relations. Elisabeth Ruiz-Queiro is a specialist on EU health policy and international health policy. She works as a legal consultant at the Public Health Law and Policies Unit of and in the Health Promotion Department of the World Health Organization in Geneva, where she is based now. But she was, before joining the WHO, an academic, as she prepared a PhD on the external dimension of the EU health policy at the University of Geneva, which was published as a monograph in 2021. And before that, she studied law, did an LLM at the College of Europe and a bachelor at the Universidad Autónoma de Madrid. And a current job at the WHO focuses on the regulation of digital marketing across risk factors, tobacco, alcohol, etc., all the regulations that surround this issue. And today she accepted to intervene as a guest lecturer to discuss with us the role of the EU in the global health as part of today's lecture. And as you have seen on the abstract of the lecture, but also as it was indicated, she's been made aware of the fact that you didn't have specialized or advanced law classes on EU health policy, and therefore there will be a bit of an introduction as well to these topics, so you can understand them a bit better. So the idea is to leave maybe 45 to 50 minutes for the first, I would say, for the lecture itself. And then there will be time for discussions. And so for those online or those in the room, it would be possible to interact and ask your questions or share your comments with Elisabeth. So without further ado, Elisabeth, I will leave you the floor. I'll cut the microphone here in the room simply to make sure that you are not disturbed by any interferences.
And I'm a legal consultant at the World Health Organization, where I work on what we call non-communicable diseases, or the regulation of risk factors that contribute to non-communicable diseases, which are, globally speaking, tobacco, alcohol, and unhealthy diets. But today, I will go back a little bit to the topic of my role as an academic or a researcher, which is the role of the European Union in global health, and therefore the external dimension of the EU public health policy. In order to introduce this topic, and since I guess that you haven't had many lectures on the EU health policy in general, let me go back to EU public health, generally speaking, both internally and externally. EU public health is regulated in Article 168 of the TFEU. And this provision is interesting because it's quite long. It provides quite a lot of details on the actions and activities that the European Union is supposed or is required to conduct in the area of public health, from communicable diseases to non-communicable diseases, mental health issues, etc. But it only provides the Union with a coordination or a complementary power. So in accordance with this provision, the EU only supports member states in all the areas comprised in the concept of public health. There is only one exception in paragraph 4 of Article 168. There are 3 small areas where the European Union and the member states have shared powers. And it's essentially areas that are linked or related to the internal market: sanitary and phytosanitary measures, medical devices, and blood and organ donations. But apart from those 3 exceptions, in all other areas, the European Union can only support or complement national measures. This is very interesting when we look at the actual body of legislation within the European Union. Because when we look at that legislation, what we see is that there's many legal instruments that are primarily or secondarily, let's say, linked to public health. You may all be aware of tobacco control legislation in the EU. There's directives on tobacco products, directives on tobacco advertising, for example. There's also a whole body of food legislation within the European Union, legislation on the use of additives on the labeling of foods and beverages, for example, and things like that. We, of course, also have a lot of environmental legislation, which is also very closely linked to public health. We have legislation on air pollution or legislation on waste management, for example. So all of these are examples of directives, regulations, secondary law that is adopted very closely linked to public health, but not on the basis of Article 168 of the TFEU. Instead, the EU adopts this legislation either on the basis of Article 114 of the TFEU on the internal market, or on the basis of Article 191 of the TFEU on environmental protection. In the current versions of the treaties, we also have two other provisions that are very important for public health. One is Article 35 of the Charter of Fundamental Rights of the European Union, which protects the right to health. The second one is Article 9 of the TFEU, which provides that public health needs to be taken into account in all policies and activities of the European Union. Both of those provisions are not directly applicable as such, but they are used very often by the Court of Justice of the European Union, but also by the European Commission in order to interpret other regulations and directives, other provisions of the treaties, in order to support other activities of the European Union. So as you can see, there is a sort of distinction in EU law between the specific provision on public health in Article 168 of the TFEU and the actual activity of the European Union and of all of its institutions in the area of public health. So this relates to this second slide, which is on the EU institutional structure in health matters. In principle, we could think that because Article 168 of the TFEU only provides for a complementary power of the Union, there won't be a very strong institutional structure in health matters. However, when we look at it, we see that there is a whole institutional body that has been built around public health in the European Union. Of course, at the heart of it is the European Commission as the executive body of the European Union. Within the European Commission, we have DG Santé, which is the main Directorate General in health matters. But because of the use of other legal bases to legislate in public health, we also have the Directorate General for the internal market or the one for the environment, etc., that will also come into play. After COVID-19, we also have a sub-body within the European Commission that has been created, which is the Authority on Health Emergencies, ERA, which is in charge of monitoring and assuring or guaranteeing the stockpile of medicines and vaccines against public health emergencies. But public health is actually a very technical area. So policy officers within the European Commission may not always have the necessary technical expertise to provide advice in health matters. And this is why we have a number of agencies that have been created in order to provide advice to the European Commission on the authorization of medicines and vaccines or food standards, etc. There's many agencies that directly or indirectly deal with health matters, but just to mention the three most important ones, we will of course mention the European Centre on Disease Prevention and Control, the ECDC, which is in charge of sharing information among member states and making recommendations when there is a public health emergency, a communicable disease. We have the European Medicines Agency, which is the agency that will provide recommendations on the authorization of new medicines within the European Union. And then we have the European Food Safety Authority, which will provide advice on food safety standards. So the food that we eat, what kind of criteria it needs to comply with so that it can be sold and consumed within the European Union. As I was saying earlier, the Court of Justice of the European Union also plays an important role in this area because it has been instrumental at interpreting, in particular, Article 9 of the TFEU and 35 of the Charter, but also, for example, Article 114 of the TFEU and how this provision can be used to adopt public health-related legislation. Because public health is a coordination area, member states also play a very important role, of course. Each member state will have their own public health policy, their own measures, and therefore coordination will be very important. But now, when we're talking about the external dimension of the EU public health policy, we need to look beyond the borders of the European Union. And here, of course, the first organization that comes to mind is WHO, as the main international organization dealing with health matters. So the relationship between the EU and its member states and the WHO will be very important here. But beyond WHO, we have other things to look at the international level, most importantly, bilateral agreements. So the European Union negotiates a lot of trade and investment agreements with third countries, and those agreements often contain provisions on trade and tariffs, on regulatory barriers or the reduction of regulatory barriers. And from this perspective, they can have an impact on food safety standards, on taxes, on tariffs, on the interpretation of the precautionary principle, etc. So on different concepts that will have an impact on public health protection as well. So as you can see, it's a sort of complex framework where we need to look at different institutions, different levels of governance, and of course, both technical and more of policy bodies. Now, when we talk about the external dimension of the EU public health policy, why do we talk about that? Why is global health important, or why has the globalization of public health become a topic of such important discussion? When we talk about global health, if now I asked you what you think that global health is, probably all of you would mention at some point COVID-19, or maybe Ebola, or HIV/AIDS. These are what we call communicable diseases. And it's the first thing that comes to our mind when we talk about global health, or when we think about the need to cooperate at the global level on public health matters. Communicable diseases are contagious from one person to the other, and therefore the need to cooperate in order to stop or to reduce this transmission becomes imperative. However, the globalization of public health goes beyond communicable diseases, and it also covers what we call non-communicable diseases. So non-communicable diseases are all those diseases that are not contagious, that can be developed either due to genetic factors, either due to our lifestyle, our habits. And so this would cover cardiovascular diseases, cancers, diabetes, etc. Of course, these diseases are not contagious. So the fact that I have one of those diseases doesn't mean that I will transmit it to my neighbor or to another person if now I travel to another country. However, these diseases are often strengthened, or their risk increases due to choices in our lifestyle. The food that we eat, the beverages that we drink, the habits that we have, whether we do physical activity or not, whether we drink alcohol or not, whether we smoke or we don't, etc. And those lifestyle risks have become very global over time. So the food that we eat in Europe is actually quite similar to the food that is eaten in the United States, or that is eaten in Australia, or that is eaten in Vietnam, for example. Because all these industries, the alcohol, tobacco, and food industries, are industries that are very global. So they are very concentrated with very big groups that act at the global level, and therefore that sell their products all over the world in a very similar manner. Therefore, the need to address those risks has become a global issue, because global action will allow to actually reduce the consumption of those unhealthy or harmful products all over the world. So it is in this context that the European Union, as any other actor at the international level, needs to think, okay, what can I do at the global level beyond my own policy within my own borders? And here comes the question for the European Union of what role can it actually play in global health? And it needs to consider a number of criteria, a number of factors when thinking about its possible actions at the global level. The first thing is that Article 168, paragraph 3 of the TFEU requires the Union and its member states to foster cooperation with third countries and international organizations. So there is a requirement in the treaties to act in the area of global health. We also know that the European Union has the international legal personality and it has the capacity to conclude international agreements and to participate in international organizations. So there is this ability for the Union to play a role in external relations, to play a role at the global level. On the other hand, as I was just mentioning, the competence of the European Union in public health is limited. It has a support competence when it acts on the basis of Article 168 of the TFEU. But at the global level, it can also use other legal bases, as it does internally. So it has to manage these legal bases and the different provisions that will allow its own actions at the global level in a good or in a practical way, let's say. Lastly, an important factor for the role of the EU globally is the fact that the European Union is not a country. It is a regional economic integration organization, as they are called at the international level. And regional organizations can or cannot play a role in international organizations depending on the constitutional rules of that international organization. So some international organizations are open to regional organizations becoming parties or member states, whereas others only allow states to be parties or member states. So for the European Union, the fact that it is not a state may limit its ability to act at the global level. So now, what happens at the WHO? If the European Union wants to act in global health, the first organization to look at will, of course, be the WHO. So what are the possibilities of the European Union within this international organization in particular? If we look at WHO Constitution, we see in Article 3 that WHO is what we call a state-centered organization. This means that in accordance with this provision, WHO is only open to membership of states, but not membership of regional economic integration organizations. WHO is a Second World War organization, and those organizations that were created right after the Second World War were very often state-centered. They didn't think about other structures than states when creating international organizations at that time, and this is the case of WHO. Another important element in WHO Constitution, we'll see later why, is that this constitution gives WHO what we call treaty-making powers. So it means that under WHO Constitution, the WHO can adopt international agreements. And in the Constitution, there are two different sorts of international agreements that can be adopted by the WHO. Conventions under Article 19 and regulations under Article 21. And I will explain later the difference and why this is important for the European Union. So considering these constitutional rules, as I was saying, this means that the European Union cannot become a member state of WHO because it is not a state, and WHO Constitution does not provide any possibility for other entities than states to become a member state of WHO. So the European Union has been granted an observer status at WHO, but there is no plan for it to become a member state. This would require modifying the constitution of WHO, and modifying the constitution would require an agreement within the World Health Assembly, which is the main body of WHO constituted by all member states of WHO. And as you can imagine, there could be many countries within the WHO that would oppose to such a modification. So the European Union is an observer at the WHO, which it means that it can attend meetings, but it can only speak after all the member states have spoken. It can access non-confidential information, but it cannot access confidential information. And most importantly, it doesn't have a right to vote. So at the WHO, when decisions are taken for the activities and resolutions and all the programs that the WHO will be developing, the European Union will never be able to vote. Does this mean that the European Union doesn't play any role at all at the WHO? Not at all. It does provide some influence in a more indirect way. And there are different ways in which this is done. The first one is through its financial contributions. So even if the EU is not a member state of the WHO, it is one of the main contributors to the budget of the WHO. As you can see in this image, it is the fifth main contributor, right after the United States until now, Germany, and two civil society organizations, the Bill and Melinda Gates Foundation and the Global Alliance for Vaccines, Gavi. So as you can see from this graph, in WHO, there's member states that contribute financially, but there's also other entities, such as the European Union and civil society organizations. These other entities can also contribute. They can put money to the budget of WHO, and they can decide where this money goes. On the other hand, member states, they have compulsory contributions. And so the contributions from member states, a part of it, they cannot decide where the money goes. It goes to the general budget, and then the WHO decides how to use that money. And then they can add additional contributions that will be voluntary, and they will decide where it goes. So in WHO, we have money that goes to the general budget and money that is directly assigned to specific programs and projects. So the advantage of the European Union is that because its contributions are voluntary, they are not compulsory, they can always decide where their money will go. And from this perspective, they can have a say in the agenda of the World Health Organization. Another way in which the European Union participates in the WHO is through its coordination meetings. So for example, if you ever attend a meeting either of the executive board of the WHO or of the World Health Assembly, the two main bodies of WHO, you will see that there will always be a member state of the European Union, usually the one holding the presidency at the time, that will be speaking on behalf of the European Union and its member states. So even if the European Union cannot speak as such or can only speak after everyone has spoken, they will still coordinate a common position prior to any meeting of WHO. So usually there will be an aligned position, a coordinated position that will be presented by the member state holding the EU presidency. Of course, there will be matters where no agreement will be reached, and therefore those will not be covered by this statement. And then each member state can say different things on those matters where there is no agreement. But for the others, there will be this sort of alignment. And what is important is that very often it's not just EU member states, but also other countries, typically acceding countries or countries of the EEA, that will also align with those statements. Lastly, WHO is what we call a three-level organization. So there is the headquarters, which are in Geneva. There are regional offices. So there are 6 regional offices across the world. And then there are country offices in many member states, not in all of them, especially in Europe. There's many countries that do not have any country office. But in many regions of the world, there's one country office in every single country. The European Union plays a very strong role in the Regional Office for Europe, which is established in Copenhagen in Denmark. In the European region, the members are all EU member states, plus a number of Eastern European and Central Asian countries. So in that specific regional office, EU member states and the European Union in particular have a very strong role. They have a majority of countries among the entire membership. And so it's a very good place for the European Union to play a strong role. Again, without a right to vote, etc., but a very strong informal influence. And so they provide a lot of funding to many programs, and they do play a very influential role there. So this relationship between the EU and WHO has actually been officialized. this observer status and different ways in which the two organizations cooperate is officialized through an exchange of letters. But the last exchange of letters was in the year 2000, so it was 25 years ago, and there hasn't been any specific renewal. It works quite well as it works right now, but it's true that there has never been an update. There was one in 1982 and then one in the year 2000. And since then, there hasn't been any new exchange of letters recently. As I was saying earlier, in WHO, one thing is the participation of the EU in the institutional structure of WHO. But as I was saying, WHO also has treaty-making powers. So WHO can adopt international agreements. It hasn't made a great use of these treaty-making powers, but there are two agreements that have been adopted so far and one that is under negotiation currently. So the two agreements that we already have are the Framework Convention on Tobacco Control of 2003 and the International Health Regulations. And now WHO member states are negotiating a pandemic agreement. You may already have heard about it. We will discuss it a little bit later as well. So the Framework Convention on Tobacco Control is the main international agreement to fight against tobacco with the aim of reducing tobacco consumption around the world. The European Union participated very strongly in the negotiations of the FCTC, of the Framework Convention on Tobacco Control. And it did so because at the time where the negotiations started, the European Union had already adopted the Tobacco Products Directive and the Tobacco Advertising Directive, the previous ones, not the new versions that we now have. And it had adopted those directives on the basis of Article 114 of the TFEU. And the Court of Justice of the European Union had ruled that Article 114 of the TFEU was an appropriate legal basis to adopt those directives. So the European Union knew that it had the competence to act on tobacco control based on its internal market powers. And based on that, it could also participate in the negotiations of the FCTC. And it actually played a very strong role by basically promoting its internal standards, its internal rules. So the rules that were provided in those directives into the international agreement. So the result is that many of the provisions that are contained in the FCTC are actually very similar to the wording that was used in the directives that had been adopted at the time. As I was saying earlier, in WHO or in WHO Constitution, there are two sorts of international agreements, conventions and regulations. The FCTC, as the name indicates, is a convention. And conventions are an interesting tool because they are adopted within the WHO by the World Health Assembly. But once they are adopted, each member state needs to ratify it. And only once a certain number of countries have ratified it, it will come into force. So it doesn't enter into force for all WHO member states, but only for those that have ratified it. Because it has this open nature, conventions can include a provision, a clause, allowing for regional economic integration organizations to also become contracting parties. So in the FCTC, Article 35, Paragraph 1, allows regional economic integration organizations to become a contracting party to the convention. And in accordance with that provision, the European Union was able to ratify the FCTC and to adopt it. On the other hand, we have the International Health Regulations, adopted in 2005. Those regulations deal with cross-border health threats. So the objective of the regulations is to provide for rules in the case there is a communicable disease that appears. So the international health regulations have been used during Ebola or during COVID-19, for example, in recent times. As the name indicates, the IHR are a regulation, and under the WHO Constitution, the regulations come into force for all WHO member states once they are adopted by the World Health Assembly. So when there is a consensus at the World Health Assembly, those will directly come into force, even though, of course, some member states will need to adopt a national law and so on. This will depend on the internal law of each member state. But so they don't need to be ratified by each WHO member state. They are directly applicable to all of them, except for those member states that would make a reservation or that would decide to opt out from the agreement. But a consequence of this rule is that they only come into force for WHO member states. They are not open to third parties, for example, regional economic integration organization. Therefore, the European Union is actually not a party to the IHR because it is not a WHO member state. Moreover, the IHR deal very specifically with cross-border health threats, where the competence of the Union is really based on Article 168 of the FEU. So here we are in an area of complementary competence. Therefore, the influence that the European Union played during the negotiations of the IHR was quite limited. It wasn't really negotiating because it was not a WHO member state. It didn't have a strong competence at the internal level. So the only thing that it could do was trying to coordinate positions among member states prior to each negotiating round. And that was basically it. Now you may have heard that WHO member states are negotiating a pandemic agreement. This pandemic agreement, although the final text is still not available, seems that will take the form of a convention. And there is actually a provision in Article 32 of the draft agreement that allows regional economic integration organizations to actually join, to become a contracting party. And the European Union has been participating in all negotiating rounds until now. And we'll see later in the next slide that it has tried to actually influence the outcome of the negotiations and to put forward some of its positions. However, if you're following a little bit the activity, you may know that the outcome of those negotiations is still unknown, especially with the withdrawal of the United States from WHO, and of course the withdrawal as well from those negotiations. It is uncertain whether an agreement will be reached. So right now, the deadline to reach an agreement is the next World Health Assembly, so May 2025, but it remains to be seen how things will evolve. Since the withdrawal of the United States, there hasn't been any negotiating round. The next negotiating round starts next Monday. So we will see there whether the United States are present or not, and whether they present any position at all or not. So we've seen until now what participation the European Union is having within the WHO. But another interesting aspect of EU-WHO cooperation is what I've called here cooperation through integration. So how the European Union integrates WHO within its own activities or within its own legal acts. And I've put here the example of cross-border threats to health. Following COVID-19, the European Union adopted a new regulation on cross-border threats to health. It already had a directive prior to that, but it was quite a weak directive with a decision. Actually, it was not even a directive. It was a decision with no major, a lot of coordination functions, but not many compulsory rules, and not very strong. It didn't work very well during COVID. And so following COVID-19, the European Commission proposed a new regulation that was eventually adopted. And when we look at this regulation, it's interesting because there are many references to WHO throughout the text of the regulation. And we see the interest that the European Union has in integrating WHO within its own activities and work. So it creates a framework for enhanced cooperation between the European Commission and WHO. It provides the need for an exchange of information between the two organizations. It creates an advisory committee on public health emergencies where WHO is invited as an observer. It also creates a health security committee, and again, WHO is invited as an observer, and a network for epidemiological surveillance, where again, WHO is also invited as an observer. So it tries to integrate WHO within its own activities, either by creating meetings where the two organizations can share information, either by inviting representatives of WHO to observe some of its meetings in order to allow an alignment or a sort of coordination between the activities of one organization and the other. So it is interesting to see that an organization such as the EU, which is not a member state of WHO, still strongly relies on the guidance, recommendations, and advice of WHO and tries to integrate it within its own activities in order to facilitate this coordination and alignment. Moving now to how specifically the EU sees its own global health action. In 2022, so the public health field in the European Union, I'm only mentioning instruments of 2022 and so on, because it dramatically changed following COVID-19. So due to all the inconsistencies and gaps and so on that were seen during the pandemic, the European Commission decided that it needed to act on that. It needed to change the way in which things worked in the area of public health. And therefore, it adopted a number of instruments and institutional modifications and so on. And at the policy level for global health, the main instrument was the Global Health Strategy, which is a European Commission communication adopted in 2022 that provides for the main recommendations, priorities, and objectives of the European Union in global health for the years to come. So it's interesting to look at how the European Union sees itself, its role in global health. And in this communication, we see that the European Union has three main priorities, which are actually the three main areas that we always consider when we talk about public health. One is global health threats, pandemics, communicable diseases in general, etc. Second is what they call the well-being of people, which WHO calls more like health promotion. At the end, it's prevention of non-communicable diseases as a big area. And the third one is healthcare services. So universal health coverage, workforce matters, the mobility of doctors and other health workforce, etc. And so for each of these three areas, the European Commission in this strategy provides for a number of priorities. In the area of global health threats, it's mainly about the modification or the adoption of new legal international instruments. In the case of the well-being of people, it's really about sustainable development and what we call the commercial, social, and environmental determinants of health. And then for healthcare services, it's, as I was saying, universal health coverage and workforce imbalances. So I'll go through each of them to provide you a little bit more details on what they mean and what the European Commission wants for each of them. First of all, for global health threats, as I was saying, the main priority in 2022 of the European Commission was to modify the international health regulations and to adopt a new pandemic agreement. At the time, the European Commission said that the new pandemic agreement would be adopted in 2 years. This deadline passed last spring. The pandemic agreement was not adopted. It has been extended for 1 more year, and we need to see what will actually happen, as I was saying earlier. In this area, we see that the European Union reached the first objective. The IHR were modified. There were some interesting modifications, and reached the second objectives in the sense that it allowed for the negotiations for a pandemic agreement were initiated. But it remains to be seen whether they will be concluded as well. But they were initiated by the European Union, so that was an important outcome for the EU. One thing then is to initiate the negotiations. The second thing is to obtain in this new agreement the outcomes that you want to obtain. And here the European Union had a number of objectives, some of which have been reached, others are unlikely to be reached. For example, the European Union has managed to have a convention for the pandemic agreement. So there is a clause allowing the European Union to be a contracting party. So that would be an important outcome for the EU, of course. But then the European Union had a number of substantive priorities. For example, the European Union has always, for a very long time already, advocated for what we call the One Health approach, which is a principle according to which you should treat health, environmental health, and animal health in a connected way. So you cannot consider only human health alone, but you have to consider how environmental factors and the interconnection between wildlife and human life resulting in the spread of a number of diseases and so on. And these connections need to be included in the pandemic agreement. For the moment, this topic has been incorporated into the agreement, but there is a very strong disagreement among negotiating parties as to what the One Health approach actually means and what the consequences need to be what the obligations need to be for contracting parties on the One Health approach. So it is a mitigated outcome at the moment for the EU. The EU also has a very strong focus on what we call antimicrobial resistance. So in public health, antimicrobial resistance refers to the resistance that humans are having increasingly to antibiotics. So because there are antibiotics in the environment, in the food that we eat, and so on, humans are developing a resistance to them. And so it means that in the future, diseases that now can be cured will not be cured anymore because our bodies will not respond to the antibiotics. And so you need to adopt a number of measures in order to reduce the use of antibiotics in farms, for example, so that we don't have it in the food that we eat. You need to reduce the waste of antibiotics in water, for example, etc. So you need to adopt a number of measures, and these should help in dealing with antimicrobial resistance. So for the EU, this is a very strong priority, and they have managed to bring the topic into the negotiations. But again, it is an area that is being one of the most sensitive ones in the negotiations. So there is still a very strong disagreement among negotiating parties. One of the main priorities of the European Union since COVID-19, in general, both internally and externally, has been on medical countermeasures. So access to medicines, access to vaccines, access to protective equipment, the strengthening of our supply chains in the European Union in order to be able to produce enough medicines and medical countermeasures when a pandemic arises, for example. These kind of things have been a very strong priority of the Union. As I was saying earlier, internally, the European Union has created HERA, so this authority for public health emergencies, which deals specifically with medical countermeasures at the internal level. It has also adopted a regulation on medical countermeasures within the European Union. So internally, it's a very strong priority, and externally as well. And here, the European Union has been quite successful. Medical countermeasures and equity in the access to them is a strong part both of the pandemic agreement and of the international health regulations. So there's a lot of provisions on creating joint procurement mechanisms for medical countermeasures, on strengthening transparency to the access and to the development of new medical countermeasures, etc. And then there's two smaller priorities that were priorities for the modifications of the international health regulations, where the European Union has not been very successful. One was that the European Union wanted to create what we call a regional public health emergency, so that when there is a public health emergency, before WHO can create a public health emergency of international concern at the global level, regions should be able to declare regional public health emergencies, which would allow to already require a number of measures, of public health measures and response measures before reaching the global level, which may be too late to adopt some of those measures because the disease has already spread all over the world. But this regional public health emergency was not incorporated to the IHR. And the second was that the European Union wanted to export its digital certificates, these COVID-19 certificates that we all had on our phones to travel and to enter certain places and so on. It wanted to export this model to the global level. And there were some provisions that were incorporated in the IHR on medical certificates, but it was not as strong and it was not as comprehensive as the ones that the European Union was promoting. So as you can see, in the area of global health threats, there was quite a lot of, the main priorities were on those negotiations, and this is still ongoing. So it remains to be seen how successful the EU will be in this area. In the area of the well-being of people, as I was saying here, the European Union is advocating for the integration of the Sustainable Development Goals on health and well-being, and also looking at what we call the social, commercial, and environmental determinants of health. So under these concepts, what we understand is that our health, whether we develop a number of non-communicable diseases or not, does not only depend on our own individual decisions, but it actually depends on a number of factors in our life. On the one hand, we have the social determinants of health, which are the neighborhood where we are born, our educational level or access to education, healthcare facilities and infrastructures that we have in our community, and our social and community context. So basically, where we are born and where we grow up will determine access to a number of preventive measures that will increase or decrease our risk of developing a number of diseases and illness throughout our life. The commercial determinants of health refer to all these strategies developed by the industry, typically the tobacco industry, the food industry, the alcohol industry, that through their marketing, through their labeling, through their lobbying, through all their own commercial strategies, they will push people to consume certain products over others. So it means that when we start smoking, it's not only our individual decision, but it is the result of a number of strategies developed by very big corporate groups that have huge amounts of spending in marketing, in public relations, etc., and therefore that normalize or render more attractive certain products and that push us or push social groups to actually smoke or eat unhealthy food or drink alcohol, etc. And lastly, we have the environmental determinants of health, which here we link health with environmental factors, such as having access to safe water, having access to affordable energy, having living in a city that is clean and sustainable, etc. And so all those environmental factors will also influence our health and therefore are also one of the preventive actions that we can take in order to prevent the development of non-communicable diseases. So the European Union has a strong focus on legislating in all these areas. It's one of its objectives, for example, to amend and to modify the Tobacco Products Directive. It wants to adopt new rules on the labeling of alcoholic beverages. Food legislation also needs to be amended, etc. And so there were a number of priorities in regulating all these risk factors and acting on all those determinants of health in order to prevent the development of non-communicable diseases. And lastly, very briefly to conclude, the third priority of the global health strategy is on healthcare services. And here, as I was saying, we have on the one hand, universal health coverage, which is also one of the main priorities within WHO. And as we can see on the map on the left, universal health coverage is quite strong already within especially the western part of the European Union, but in Europe in general, and it is not in other areas of the world. So promoting the approach towards universal health coverage at the global level is one of the priorities of the Union. On the other hand, another big problem that was that is visible in general, but it was very visible during COVID-19, for example, is on imbalances in workforce around the world, in health workforce around the world. So what we see is a very strong migration of health workers between regions of the world. And this is visible within the European Union if we take doctors and health workers from Southern European countries to Northern European countries, or from Eastern countries to Western countries. But it is also very visible at the global level, with health workers moving from one area to the other, because, of course, salaries and working conditions may be very different in one region and the other. In some countries, we have aging populations, so a stronger need for doctors. In others, we have many doctors being trained, but not very good working conditions, and so on. And so people migrate. And this creates strong gaps of health workers in certain areas of the world. And these can be very problematic when there is, for example, a public health emergency, but even in the regular work of health workers. And in order to address this, of course, the European Union has a number of regulations and directives, etc., on health workers within the European Union. And at the global level, there is a non-legally binding code on the migration of health workers as well, which provides recommendations on how to address this, how to prioritize the migration of health workers, etc. And so this is the second big priority of the European Union in this area. So what we see from the global health strategy is really a comprehensive approach to global health, where the European Union puts its own priorities for each of the big areas that are typically considered when we talk about global health. And then over the years, we're seeing where the priorities have been undertaken or not. So, for example, we see that the negotiations of the pandemic agreement are ongoing and the European Union is quite involved in it. We see that legislation on well-being, as I was saying, on the determinants of health and so on, has been much slower than was expected. So there was a number of proposals that were put in that strategy, but that have never materialized. And then in healthcare services, the action has also been quite limited from the European Union. So let's see a little bit now with the new Commission and so on, how those priorities change potentially, and where the new priorities will be for the coming years. So I'll stop now here for the presentation, but I'm happy to take any questions and to have a discussion with all of you. Thank you very much.
Thank you, Elizabeth. Thanks for your